Listeners, if you enjoy The Nocturnist, then you'll also enjoy Unleashed, Redesigning Healthcare, a new podcast about clinician-led innovation on the front lines of care. The featured guests are the clinician innovators themselves, their stories, their voices, their ingenuity, their commitment to their patients, and their humanity, and even the deeply felt gains in their own well-being. Unleashed is from our friends at the Dartmouth Institute, one of our sponsors for this episode. Learn more in today's show notes or search for Unleashed, Redesigning Healthcare anywhere you listen to podcasts. Support for The Nocturnist comes from the California Medical Association.
At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
Moscow television tonight.
On April 26, 1986, a late-night safety test at Chernobyl's Reactor 4 triggered an explosion, blasting off the reactor lid and unleashing massive radiation. The worst nuclear disaster in history.
The Soviet Union admits it has had a nuclear accident, and it's clearly a major one.
As the crisis unfolded, the world scrambled to understand what had caused the explosion.
So many rumors, so much different gossip, that will be very difficult to determine what has really happened. But I think you asked a very...
It took months to uncover the full story, but one thing was clear. Chernobyl wasn't a single mistake. It was a systems failure, a combination of flawed reactor design, operator error, and a Soviet culture that prioritized obedience over safety. That night, as operators disabled key safety systems, if anyone knew how risky what they were doing was, no one dared challenge the orders. In aviation, a similar pattern led to the deadliest plane crash in history, when two fully loaded planes collided on a foggy runway in Tenerife, Spain, because of miscommunication, hierarchy, and a culture of fear.
At least 578 people died.
After these disasters, entire industries changed. Nuclear power and aviation transformed how they investigate failures, to ask not just what happened, but why. And how do we make sure it never happens again?
Critical evidence will come from the wreckage, the onboard recorders.
But what about medicine? Who investigates when the disaster isn't a nuclear meltdown or a plane crash, but a fatal medical error?
Do you have redundancies in place? What are the fail-safes in your system? Are you using checklists and complying with checklists?
Dr. Ron Wyatt has spent his career investigating failures in hospitals, what medicine calls sentinel events, preventable errors that lead to death, permanent harm, or catastrophic injury.
If you say someone died and we're going to retrain 100 people over the next 6 months, we kind of say, well, you should be doing that anyway.
He's been an industry leader in defining how hospitals can effectively respond to these events to actually make sure they never happen again. And what he's seen over and over is that sentinel events don't just happen because people don't know enough. They happen when uncertainty is ignored. When people can't ask questions or speak up, mistakes go unchecked and harm follows. Today, we talk to Ron about uncertainty, how it shapes systems, how embracing it can prevent disaster, and how suppressing it can be deadly. This is The Nocturnist, Uncertainty in Medicine. Dr. Ron Wyatt is an internal medicine physician and nationally recognized expert in patient safety. He was actually the first patient safety officer at the Joint Commission, the organization that accredits and certifies hospitals across the U.S. And while this might sound like a slightly unglamorous position to those outside the world of medicine, it's actually a pretty big deal. Before 1951, hospitals operated with almost no oversight. Care was inconsistent, preventable deaths were more common, and no national safety standards existed. The Joint Commission was created to change that. It establishes safety guidelines, conducts inspections, and investigates sentinel events like maternal deaths, wrong site surgeries, medication mix-ups, retained surgical instruments, even assaults on patients or staff. Over his 15 years with the Joint Commission, Ron analyzed the causes behind thousands of these failures.
Human-machine interaction, human-technology interaction, the environment where the event took place, down to the type of flooring, the type of lighting, all those kind of things that contribute to team fatigue.
It was Ron's job to help hospitals figure out why something had happened, almost like a Sherlock Holmes of patient safety.
We would go through that kind of detail to say, tell me how you marking your surgical sites. Does everybody understand before the procedure starts what that means?
In this role, Ron had to doggedly track down every possible reason that, for example, the necessary surgical equipment wasn't on hand when it should have been.
Why weren't they there? Well, it didn't come up from SPD. Why didn't it come from SPD? Well, we were understaffed in SPD. Why were you understaffed in SPD? Well, somebody called.
This sleuthing, this advocacy for patient safety, it's something Ron is deeply passionate about.
What really drove that latent condition, all kinds of dynamics that contribute to somebody getting hurt or getting killed.
In his 15 years of working with the Joint Commission, Ron said he saw it all. Again, there are all kinds of dynamics that can lead to someone getting hurt or getting killed. But one of his major contributions to the field has been highlighting the roles that bias, racism, and prejudice can play as critical yet overlooked factors in patient safety. These forces, just like misdiagnosis or surgical error, can lead to serious harm and even death. He says this reality first became apparent to him at a very early age.
I grew up in the Black Belt in Alabama, born in Selma. Grew up in a very rural area on a dirt road in Perry County, Alabama. The closest town, I guess, would be called Heiberger. And the interesting thing about that is Chris Scott King is my cousin. We all went to the same church and we kind of all grew up together. Probably around the time I was 14, there was a story that came to the community from a place, interesting name, Uniontown, Alabama. And the story was that a mother had taken her child in to a general practitioner for a laceration. And once the wound was sutured, the mother said to the general practitioner that she didn't have any money to pay. And at that point, the story came to us that he took the sutures out. And the mother then took the child to a veterinarian, and the veterinarian put the sutures back in. And hearing that story, I thought, okay, that maybe it's something I can do here and just be a physician and come back to the Black Belt. So that's probably the genesis of all of it. I think I was probably about 14 or 15 when we heard that story.
That story stuck with Ron and became a driving force for him throughout medical school. Soon, he was ready for residency.
I thought that I would end up back in the Black Belt to practice medicine. And I had physicians who finished medical school and training before me that had gone back as a part of the National Health Service. And they all described just nightmarish experiences trying to practice as a Black physician in the Black Belt. It was almost terrorism. And they advised me not to come back there, so I didn't.
Instead, he went to St. Louis. He said it was there that he got his next major lesson in the types of harm possible in medicine.
As a resident, the chairman of medicine had these sessions. His name was Coy Fish. He's deceased now. On Fridays at 5 o'clock, we would have these sessions, and we called them Fish Fries. As you came in, he had pulled charts, and he would go through what had happened to that patient, not from a purely clinical perspective, but what was the care like? And is it safe or not? That's when I became interested and started to see how much harm we were doing. The other interesting thing was when we went to what was called morning report, there was always a priest there. It was a Jesuit hospital. And the priest that was there would always kind of bring us back to, did we treat this person with compassion and respect? And, you start thinking, what was the care like? Right? How was this person treated? And I saw a lot of harm that was preventable and saw a lot of bias and a lot of racism.
It became clear to Ron that for many patients, uncertainty in medicine isn't just about a diagnosis or treatment plan. It's about not knowing if they'll be seen or heard or even valued as human beings. This recognition and a desire to change it has formed the basis of Ron's practice. For example, he told us about a patient he saw back when he was practicing in Huntsville, Alabama, years after residency.
And I remember a patient in her mid-40s, Black female, type 2 diabetic, who came to the clinic here in Huntsville to see me. The endocrinologist that cared for her taught me in medical school. She comes in, we do a random finger stick glucose, blood sugar, and it was not measurable. It was so high. I had her come back the next day. We did a hemoglobin A1C that was like 13 or something. So I talked to her about what we needed to do to get her diabetes under control. And I said to her, we're going to get your hemoglobin A1C under 8, and we're going to get your fasting glucose to under 140. And she started crying. And my first thought was, okay, did I insult her? Did I say something the wrong way? And I said, so why are you so upset? And she said that this doctor that, again, taught me in medical school, she said he told me that no matter what I did, my blood sugar would never be normal. And you're telling me it can be normal. I've never heard that. So, that to me wraps up, and that's harm. That's not safe. It's unsafe. And, I could go on about, just all kinds of stories about medication related errors and diagnoses that are obvious but overlooked for reasons of bias and racism and discrimination.
This type of manufactured uncertainty plays out across medicine every day. A woman's pain is dismissed as exaggerated. A Black patient receives a lower dose of pain medication. Language barriers turn routine care into guesswork. In 2023, Ron and his team at the Joint Commission released a report containing data on more than 1,400 sentinel events across the country. Of the events in the report, 48% of them were patient falls, and 8% each were wrong site surgeries, unintended retention of a foreign object, and assault, rape, and homicide. Delay in treatment and suicide came after that, at 6% and 5% respectively. Interestingly, almost all the events, 96% of them, were self-reported, a testament to how important it is for hospitals to stay in good standing with the Joint Commission.
When we look at root causes, and I look at them every year, they haven't changed in 15 years. We always came to leadership, communication, teamwork. Those are always the top 3 root causes.
This has major implications for how we solve for patient safety, because it shows that sentinel events don't boil down to individual actions, but to how systems function. Just like Chernobyl and just like Tenerife, sentinel events happen because of how groups of people work together, because of culture. And changing culture can be challenging.
What people have put in their analysis is we're going to work on having a quote unquote just culture. Oh, that's fine and dandy. That's going to take you 10 years at a minimum if you're doing all the things you should be doing. So great, put that in there. The fact of the matter is, what are you going to do to mitigate the risk?
Ron and his team found that while a lack of safety culture was often the root cause of sentinel events, trying to fix the culture alone didn't work.
What we typically saw was the most ineffective corrective action was education and training or rewriting a policy. And we reached a point at the Joint Commission, if an organization submitted a comprehensive systematic analysis, and if their corrective action was mainly at the level of education and rewriting a policy, we actually rejected it. We said it was not credible.
Patient safety work, Ron says, has to include tangible, concrete systems changes, things that make uncertainty visible before something bad happens.
Timeouts, checklists, checking the wristband to make sure it's the right person. They come back to the things that we know already exist and have pretty good evidence that they work.
And to catalyze a culture change on top of these protocols, that's a top-down thing. It starts with leadership. For example, Ron told us about a series of cases he started seeing a few years ago in which patients who had undergone abdominal surgery kept coming back to the hospital in bad shape.
These folks would come back bleeding, they'd come back septic, some would come back and die. So we wanted to understand what was it about this that was being missed, I'll put it that way. We already knew what kind of patient was at the highest risk for one of those types of events. Intra-abdominal surgery on a person that we don't use the term anymore, but people that had a BMI over 35. So the question became, first, you knew this person was high risk. Why didn't you take extra precautions? The next was, we often saw someone in that procedure knew that something had happened. They knew that a viscus had been cut. They knew that a blood vessel had been cut, and no one said anything.
Stories like this show just how many factors go into patient safety. Did the surgical team take safety precautions during the procedure? How many people in the room suspected that something may have gone wrong and didn't speak up? Would their behavior have been different if the patient on the table had been thin? Ron says that for him, the issue isn't uncertainty, it's how we relate to it.
I will have to say, after looking at thousands of these things a year, I'm struck that it was probably uncommon that there was uncertainty. It seems as if someone always knew it was the wrong person, the wrong site, the wrong procedure, right? Someone knew. So the uncertainty in my mind is then, why didn't you speak up? And the most common thing I came back to, and why, it all flowed back to leadership. Just the fear of being punished, the fear of retribution, the fear of being fired, the fear of not being a quote unquote team player. Systems that are just ripe with the fear of doing what's right for patients.
At the end of the day, Ron said, it all boils down to leadership.
How are you communicating that you want zero preventable harm? Do you debrief with teams? Do you use simulation? Do you have town halls? Whatever those mechanisms are, a leader needs to be able to delineate those. And I won't name them, but they're some of the top patient safety people in the world. They are afraid to address this. And people protecting their positions and their rank and their titles and their income. I'm looking for my next promotion. I'm not going to commit career suicide. So that means standing by while people get hurt and you know they're getting hurt. Too much of that still goes on. But I'm hopeful because I see glimmers of things happening. The National Action Plan for Patient Safety, for example, there are things happening. So I'm going to remain, as I say, impatiently optimistic about where we're going to go from here. And hope is not a plan, but it keeps me hopeful.
At the end of our conversation with Ron, he took off his systems hat and shared a story with us from his early days in clinical training. A story about a very special mentor who shaped the way that he sees uncertainty at the bedside.
Joe V. Sapira was just a giant of a bedside diagnostician. And I followed for the 3 years of my residency. I took every opportunity that I had to work with Joe Sapira because I could see how we could be up all night troubling with what is this diagnosis? What test do we need to order? What do we need to do next? And then the next day, he would go to the bedside and he would sit with the patient on the bed and say this to the person. Now tell me what's really wrong with you. And all this history would come out and we're standing there gobsmacked that we've been up trying to chase, academic stuff, looking through the New England Journal and Annals of Internal Medicine and, whatever we could find to figure out what's going on with this person. Joe Sapira comes, sit at the bedside. He says, "Can I sit with you? I'm Joe." Right. And out would come the diagnosis. So I would say Joe taught me so much about taking the uncertainty out. Right? Tell me what's really wrong with you. Tell me why you're really here. How did that serve me later in practice? When people come in with kind of vague symptomatology and gaps in the history, I would just go straight Joe and say, now tell me what's really wrong with you. And out it would come.
Thanks for listening to the Nocturnus Uncertainty in Medicine. Our core uncertainty team includes me, the Nocturnus head of story development, Molly Rose Williams, and producer and editor, Sam Osborne. Our uncertainty correspondent is Alexa Miller of Arts Practica. Our student producers were Claire Nimura and Celine Everett. Special thanks to Maggie Jackson and Paul Hahn. Our executive producer is Allie Block. Our program director is Ashley Pettit. Our original theme music was composed by Ashton Spencer, and additional music came from Blue Dot Sessions. Artwork for Uncertainty in Medicine was created by Eleni Depot, who is represented by Folio Illustration and Animation Agency. The Nocturnist Uncertainty in Medicine was made possible by the generous support from the ABIM Foundation, the Gordon and Betty Moore Foundation, and the Josiah Macy Jr. Foundation. The Nocturnist title sponsor is the California Medical Association, a physician-led organization that works to keep the doctor-patient relationship at the heart of medicine. To learn more, visit cmadocs.org. The Nocturnist is also made possible by support from listeners like you. In fact, we recently moved over to Substack, which makes it easier than ever to support our work directly. By joining us for a monthly or annual membership, you'll become an essential part of our creative community. If you enjoy the show, consider signing up today at thenocturnist.substack.com. If you enjoy this episode, please share with a friend or colleague, post on social media, and help others find us by giving us a rating and review in your favorite podcast app. I'm your host, Emily Silverman. See you next week.